We just got our second positive inmate for COVID, and both of those are at SCI Phoenix. We don't have any positive cases anywhere else. We do have 4 staff positives. At this point, we're not identifying location of staff positives. We're working through that. DOH has some regulations that we're working through to try to adjust. It's our intent to try to put as much information about positive staff and inmates on the website, but we have some stuff we have to work out through DOH regs.
First of all, it causes to completely recalibrate reentry. I mean, big picture. We were at a place. It's almost hard to think back to where we were just 3 weeks ago before this became a way of life. We were at a place where basically we had all kinds of jobs. Folks coming out of prison were a commodity that employers were looking for. We were traveling the state doing work, employer roundtables. Now our reentry is completely different. And just let me lay out some of the challenges and some of the specifics around reentry, and then talk about really trying to release as many people as who we have discretion to release at this point. So most people who get out of prison, when they get released, they're not necessarily in a prison in their community. They hop on a bus to go back home. Most of the bus stations in the state are closed. So we're creating our own transportation network so we can transport releases back to their area. It's been a challenge for us. One of the other things that we've been ramping up on the positive side of the ledger is that we've already been above 70% in signing individuals up for medical assistance prior to release. That's become a lot more relevant now in this context where you're releasing people and access to health care is such a relevant part of reentry. So talk specifically about releases. So what we decided early on is that we were going to put all the options on the table, work through different entities to really explore how we can reduce our population in the context of this, because make no bones about it, part of our response to this has to be having less people. So for one, we looked at everyone who was beyond their minimum and haven't gotten a hearing yet, and really trying to prioritize folks getting a hearing. Now, you may or may not know that we have a parole board here, and actually the parole board has 3 vacant positions. So we're working with our partners in the Senate to get a couple people confirmed so we can really ratchet up those and really target folks who are beyond their minimum. We also re-looked at everyone who was in a state prison on a technical parole violation. That means they were in on a parole violation with no new charge. Given this context, it really made sense to review that group, and then for individuals who weren't in on the nature of the violation was not violent. There wasn't a new charge. They had completed their programming. They served an appropriate amount of time. We kicked those names over to the parole board. It was about 94 folks were kicked over to the parole board for them to review and release. We also had a group of folks who had received positive paroling actions, and but the paroling action specifically said parole upon completion of XXX program. So we looked at all of those and figured out who could program in the community, kicked that to the board, because the board is who ultimately controls releases in those kinds of circumstances. And to date, 88 people are either out or in the process of getting out to complete the programming. We still have a programming infrastructure, and we plan to maintain that programming infrastructure in the community to include inpatient and outpatient drug and alcohol, mental health, cognitive behavioral, in addition to detox. Some of these things we were There was a combination of using prison and the community. We're really trying to maximize and maintain that community infrastructure for treatment. Beyond that, we have had some discussions and are talking to, as somebody alluded to, had some discussions with the District Attorney Association, Office of Victim Advocate, and folks in the General Assembly about exploring some mechanism to look at folks who are close to release and figuring out a group that we can agree on that that we could find some mechanism to get out of prison and reduce our footprint. To date, this month, just given that mechanism, given the mechanisms that I described as far as things we were able to look at, and coupled with the fact that most county courts are closed down, so that actually reduces the amount of commitments coming in. And not to be overly simplistic, but our population is a combination of the number of people who come in and the number of people who come in and how long they stay. And so when less people come in, and assuming we keep releases at a normal rate or increase that rate, that'll really speed up the actual reduction in population. So, for instance, we average about 1,400 releases a month this year. Adding parole board members will increase that capacity by 100 or 150. Targeting people who are beyond their minimum will further speed that up. So just these existing things during the months, and coupled with a few new commitments coming, during the month of March, our population was reduced by 574 is the tally I have in front of me, and that's institutional population specifically. So that's the status of where things are now. Again, we're still exploring options and in discussions, going through all kinds of stuff, but that's where we're at. There's no specific target at this point. We're just exploring options, getting reasonable projections for those options, and then trying to be reasonable to understand that even if, let's say, we create a mechanism and there's 1,000 people who are eligible for that mechanism, understand that we won't get 1,000 people out because we have to put some guardrails on it. So there has to be a place for them to live, either a home plan or a halfway house. We have to make sure MA is turned on and we have a warm pass-off as it relates to medical continuity, especially if we're targeting people with who are immunocompromised. So we got to make sure we have, at least a month, if not more, of medication, and obviously a nexus to continued health care, and then also the treatment infrastructure if they're maintaining treatment needs. So we're just trying to again, some of crisis management and crisis response is focusing on what your resources and make sure you're getting a return on investment on applying resources to it. That's why from our staff standpoint, their focus is maximizing the heck out of the parole process. Let's make sure we're early on. We made sure the parole board and hearing examiners had electronic access, and so we got to keep those parole hearings and maximize that. Every month, for instance, right now, there's 270 parole hearings that are skipped because the board is not at their capacity. So to the extent that we can reduce that stuff, it keeps grinding. And then, so folks who were likely to get out, we do all the work. And it's really, we're talking about days worth of work now for reentry because of this new reality we're in. So I don't have a specific number, but we're just trying to maximize every existing thing we have. Based on the positive SCI Phoenix, that really is what triggered our quarantine of the whole system. So there's a couple unique things at SCI Phoenix, especially around, I would call it enhanced screening for incarcerated individuals. They're basically taking temperatures on any housing unit where there's a nexus to one of those positive tests, to really try to make sure we're identifying folks as early on as possible who are symptomatic. We're using more PPEs, specific N95s, at different housing units at SCI Phoenix and all our face-to-face medical staff. As it relates to testing, yeah, we have a testing infrastructure. Pretty early on, one of the approaches we chose to take was identifying areas that were going to become pressure points, and I would define pressure points as areas where we thought at some point it was going to become, we're either going to be a critical shortage or it's going to become an issue. So we have testing infrastructure at every one of our prisons. And actually, we're partnering with several different labs, some of which have a quicker turnaround time than others. So testing at this point is not an issue. Like everything with this virus, every day seems to be unique. But at this point, we certainly have testing, and we have more testing in the southeast region. So if you look at the state, we would anticipate that our numbers would co-vary similar to the numbers in the community. And this seems to have spread, and this is a really rough estimate, and I'm certainly not an epidemiologist, but really the southeast was the primary area of concern, and it's kind of spreading west with some issues in the northeast. And so I would assume that if, and again, hopefully our proactive steps will delay the facilities getting it, but our first wave, and two is the definition of wave, is in the southeast. So we're focusing a lot of resources in the southeast. We do have some prisons, at least one prison in a county that has 0 cases at this point. So testing, we're where we need to be today. And as far as just the overall system and the approach, our approach, I would say we're staying consistent with the administration overall, and really focusing on the areas where cases in the community are growing, because those are areas clearly with bigger risks. And to the point where we get daily reports on, you get the overall growth number across the state, and then we drill down to county by county and where our staff are living and what counties our staff are coming in from. I agree that we need to reduce our footprint to the extent possible, but to just randomly release people without true reentry planning, especially as it relates to a connection to a medical infrastructure in the community, to kick someone out with no place to live and no connection to a medical, that sounds pretty cruel and unusual to me also. So, I think we need to strike a balance. And at this point, and again, with a bunch of caveats, our steps have delayed the virus coming in to a bunch of our facilities. So we're going to continue to work to make responsible decisions, to work our butts off to make sure reentry for folks is in place, where we're helping them safely reenter society where they can be successful, and we'll continue to work in that direction.
Been a lot of angst of transfer of inmates on the federal level. How's that been like on the state level so far? Anybody coming from especially from the southeast or the northeast out this way in this part of the state? How's that been handled so far?
Yeah, well, I'm aware of the federal issues, and certainly Congressman Keller and the legislation he introduced about the feds, and obviously we don't really have any control or nexus with the federal system. As it relates to the state system, what we did is we shut down state transfers from the counties for a couple days, basically a week, while we stopped the closure of SCI retreat and turned that into our reception facility. And the thought there was, first of all, in times like this, when systems are really stressed, I don't think it makes sense to split hairs and treat counties and state. I think we have to really partner together. And frankly, when you think about pressure points, there's some county jails that really don't have the resources, the medical infrastructure in place, that if they get in a bad spot, they're going to be in a really bad spot that requires a lot of assistance from us and from other agencies, thereby pulling resources that if we're more proactive, we wouldn't need. So that's why we decided to keep taking transfers from counties with this caveat. We're really controlling it. They're going to SCI retreat. Before they're transferred, there's a pre-screening process. When they get to us, before we accept them, we re-screen them. If anybody is symptomatic, the entire van or bus gets turned around. And then as it relates to our strategy as far as housing them, you can think of it in context of we have a block at SCI retreat. So if you come in on Monday, you go to, I'm just going to say A block. So all our new commitments who come in Monday go to A block, and they're basically in quarantine on that block for 14 days, which, as I'm sure everyone knows, is the incubation period. So no one's symptomatic, nobody for 14 days, everybody's fine. Now you're out of quarantine, and you know, maybe then you get transferred to another facility and start doing your time. So that's, and then next day, Tuesday, all our new commitments on Tuesday go to B block, and then they start their 14-day quarantine. So that's the approach we're taking. We're day 3. If today's Wednesday, Sue McNaughton, help me out. Is today Wednesday?
Yes, I believe it is.
Okay. So this is
yes.
Day 3. Thank you. This is day 3 of that. We've not had to turn anybody around and not had any issues. I think we have about 170, somewhere between 150 and 170 new commits scheduled from counties this week, another 100 the following week. So thanks for that question. We also have a handful of folks who were back in county jails on writs for court, and some of which are returning to us. The counties, I got to say, have been great. We do a weekly call with all the county wardens, and just really, and as well as the sheriffs, and just really good effort within Pennsylvania to coordinate and communicate back and forth. Yes, we've been doing that for 2 weeks for all staff of all disciplines. We have a pre-screening area out in the front part of the prison that involves a structured questionnaire as well as taking temperature. We've really focused on educating the staff. Obviously, again, following this corona stuff, if they have a contact, for instance, a family member who's suspected of testing, we have a mechanism to report that. We also have medical personnel working in central office that are working with staff on making, so we've centralized the decisions that when someone is capable of coming back to work and when they're not. In any case, if we have a choice, the choice would always be immunocompromised within each subcategory first. But in some cases, as I said, we're maximizing some of our normal processes. So depending on which mechanism your release is going through, some of that would be normal, but we're always, early on we established a list, and our number at that time was about 12,000 individuals whose medical conditions would make them on our vulnerable list for COVID.
12,000 that was?
Yes, 12,000 out of, we have about 44,500 in prisons right now. I think the central PA region, currently as far as the community, I think Center County is an area that's starting to see some increase, and I think they're one of the more recent counties to go under the stay-at-home deal. I think in the center region, the two areas you're concerned about are some of our older facilities that have big housing units with hundreds of people on there. And when you talk about the need to reduce, when you drill down to be a little more specific, you want to reduce the number per housing unit. So some of those older housing units in central PA will be targets as our population drops to reduce the population on those specific housing units.
You know, there's some type of monitoring being done depending upon their connection to a positive case. But how do you determine who should get tested because so many people are asymptomatic?
Yeah, it's the same basically the same criteria that you and I are under now in the community. Although I would say the difference would be in facilities where we have concerns, we're doing a lot more kind of proactive temperature testing early on. In talking to some of our advocacy groups, they expressed concerns about, for instance, inmates hiding symptoms so they wouldn't get locked up and those kinds of things. So we kind of decentralized and we're doing more enhanced kind of proactive checking for symptoms. But as far as the testing criteria, again, same as in the community. If there's a nexus and then, at least as of last week, the process was do the quick test for influenza A and B, chest X-ray if it was indicated, and then testing. That was the CDC criteria last week. Tell you the truth, I can't. If it may have been modified between now and then, I just don't recall that.
Is there any increased ability for folks to have access to the outside world, like calling privileges, video chats, or anything like that? Thank you.
Yeah. So five free phone calls a week, and we've just extended that again, at least for the next 30 days. And then we did start this new Zoom video visitation program. It's been pretty popular. I think we've averaged about 450 Zoom visits a day with, and the feedback we've gotten from our population has been very most of the feedback has been, are you going to keep this after the emergency? And our answer generally is, let's get to the emergency first. But that's been pretty popular. We also add, I think, 5 free emails a week. So yeah, we're trying to offset the impact of not having visits.
The 2 inmates that did test positive, were they recent enrollees or whatever in the system, however you want to characterize it? Were they new inmates, or have they been in there for a while?
I don't think they were new commitments. I don't know what a while is, and I tell you the truth, I don't know how long they were in there, but it wasn't like they were new commitments in the last 14 days.
Okay.
Or the 14 days before they came in. So it wasn't. It's likely not a new commitment situation. Although one of them did have a visit before we stopped visits. That the potential exposure would have been in the window.
So you're trying to figure out how they could have got it, in other words.
Yeah. Again, we as far as tracking and the kind of stuff that you're hearing in the community, we're certainly doing the same thing here.
Thank you.
And when was the second case diagnosed?
I think it was late last night. It was sometime in the last, I'm going to say 24 hours, but I think it was late last night.
Are you guys getting your testing supplies from the Department of Health? Or are you buying them directly from manufacturers? And I'm also wondering if your staff or if you're using any testing supplies on your staff, like if your staff feel that they contracted something, or if they have symptoms that they're displaying at work, or are your supplies exclusively for prisoners?
So it's different mechanisms for testing staff and testing individuals who are incarcerated. So let's start with the incarcerated individuals. We're getting testing from multiple sources. We do have contracts for some of our medical services, and they have access to tests. We're using multiple labs. So there's a lot of flexibility built into our testing infrastructure for incarcerated individuals. As it relates to staff, they're kind of plugged into the general community and are treated like other first responders as it relates to testing. So we don't test our own staff. We plug them into the community infrastructure.
Like, what's your average turnaround on testing data? How long are you guys waiting for your results?
It varies. It's as quick as 2 to 3 days with the one lab, and I don't want to say which one because I don't want to run on them. But it varies between Probably the same thing you're hearing in the community. As quick as a couple days, as long as 5 or 6 days.
Do you think that following the general recommendations of the Department of Health for the general public for testing is sufficient, or should you be testing more aggressively and expansively, given how many people you have at risk? Like, would you like to do something closer to universal testing?
I think if whoever's not muted could mute, please. I mean, I think ideally I wish we had those instant tests for everybody, staff and inmates, and we could really come up with a good game plan to mitigate it. But no, I think the CDC guidelines for right now, today, are sufficient. I think if you look at even at the number of folks who are suspected and been tested is in the 20s. I don't have the exact number in front of me now. The vast majority of our tests are negative. I mean, we have 2 positive cases with 44,500. So I think the CDC guidelines work for today. But when I tell you we literally meet every morning, and when I say we have our command team, and one of the individuals we brought on early on was a doctor, Nick Scharf, who used to actually be the head of medical for the department, and then retired, but he specializes in public health. So we brought him back immediately, and he's been our medical advisor and consults with all our medical personnel. So, like I said, this is something we do a update on the situation every morning, first thing with our command team, and make adjustments. So at this point, yeah, I think the CDC guidelines make sense. That may change as the environment changes.
Do you guys have any plans for transport of inmates? Because I know that your ventilator supply is low, so have you taken steps to secure more ventilators? And what are your plans for treating inmates who need ventilators who aren't at a facility that has one in stock?
Yeah, I couldn't really answer that right now. We have a couple plans in general at what things would look like, but it really, it comes down to what makes sense in that environment, and location is part of I'm sorry, I just got an email and got distracted. And location, it's going to vary by location what that will look like specifically.
Why was SDI Retreat chosen as the overall quarantine site for the DOC? And does this change or extend the decision to close SDI Retreat?
One, because it was almost empty. And so it was the easiest place to do that. The fact that it really gave us the opportunity to, as I described earlier, if you were on the call, house people, really separate and have 14 different quarantine areas to ensure that someone's through the incubation period. 2, as far as what happens after this is over and what life after Corona looks like, I couldn't tell you. I hope it's soon that we're having those discussions, but I couldn't tell you.
So it's not set in stone still that it's going to close in June?
Oh, it's not closing in June. I mean, listen, I hope all this stuff goes away in the next 2 weeks, but I'd be stunned if we're ready to get back to normal by June. I would be stunned if that happened.
Thank you, sir.
This is Lizzie again, Capital Star. I was wondering if you could tell us a little bit more about just what it looks like in your prisons right now, and what share of your population is sharing living quarters with other prisoners? Are you moving people into restricted housing units just to distribute, to kind of create more distance? I mean, how closely are people living still? Sorry, that didn't make any sense. But are people still living in very close quarters?
I understood. I'll try to answer what I think I heard you say, and then you can follow up if I missed it. All right.
Okay.
So in general, most folks are living in a cell with another individual, right? So that's 100 square feet, give or take. 2 people living there. Then since the quarantine order right now, what we're trying to do is really, it minimizes their out of cell time, but when they get out, there's less people in that area. So we're really trying to limit it to groups of 10. and feeding on the housing unit. The previous iteration, before we went to total quarantine, you would have seen groups of 50-ish, like walking down to the chow hall to pick up their meal and walk back to the housing unit. So we could just we were trying to maintain movement and try and, if you're self-quarantined, you're going stir crazy, add that to the prison context. And we were trying to keep it as normalized as possible. But now we've really ratcheted it down to really minimize that. But as I described to the gentleman from, I believe, TAJ, some of our older places with these big, huge housing units, that's more of a challenge. So it would really vary by design, but we're really trying to achieve this concept of social distance to the extent possible, with the caveat being that we do have, in some cases, folks sharing a cell.
Is there, how much flexibility is there in housing? Say someone starts to show symptoms, how able are you to put that person in, single isolation or move their cellmate to a different place?
So we do have some flexibility in doing that. Again, it would vary a little bit by facility, but we do have flexibility in doing that. And that's really one of the values of reducing the amount of folks who are incarcerated, is to give us more flexibility. And keep in mind that we've already had this prior to Corona World. We've had at least two influenza outbreaks. So we have been through this kind of isolation quarantine thing, and that happens every year during flu season. The level of contagion is obviously more with this, so it's slightly different, but we've been through this before, so we have a pretty good sense of how to do that.
What is the mental atmosphere in your facilities right now? For both staff and inmates, is there a general fear of what's going on right now? I mean, can you talk about that at all? I know you spoke briefly about mental health services, but can you tell us a little bit about, the mental atmosphere in these facilities?
Yeah, there's a lot of angst. I mean, it's like anything. You get mixed stuff. I mean, a lot of folks, and we're really trying to communicate. I'm trying to do a weekly video. Our superintendents are walking around doing town halls and talking to people and using our inmate TV system to get messages out. But there's just I mean, I think it's the same as in the community in some ways, that everybody has general angst about it. People who are incarcerated worry about their families in the community. They understand, we've gotten probably more than I would have expected. We're getting feedback that they understand and appreciate the steps we're trying to take. But there's angst everywhere. I would say probably everybody on this call has family members you're concerned about. So I would say that we're trying to be cognizant of it. It was one of the reasons why we tried to delay going to a full quarantine like that as much as possible, because we didn't want to ratchet it up. But yeah, I think the best antidote to that is accurate and timely information, and trying to keep that connection to the community. As it relates to staff, yeah, there's a lot of angst with staff. They have families, child care issues, all this stuff that people in the general public are dealing with. Our first responders are dealing with also. So yeah, it's there's a lot going on right now for everybody, and we're trying to provide services both for individuals who are incarcerated. We're trying to provide support services for staff members and their families. So yeah, it's that kind of time. But again, folks are rallying and pulling together. Our incidents, even our negative incidents within the facilities, are going down. I think people are really trying to get through this. And I think one of the general framings we're trying to do is, listen, in this case, us versus them. Them is the virus, and we're really just trying to get through this and defeat this crisis we're dealing with.